Originally from Princeton, Kentucky, Mark earned his Bachelor of Architecture from the University of Tennessee, Knoxville. He's been actively involved in many organizations, including the American Institute of Architects, and is board certified as a healthcare architect by the American College of Healthcare Architects. His healthcare portfolio work includes acute care facilities, medical office buildings, and outpatient facilities, and has been involved in over 30 emergency departments over the last 5 years. Wow. And our second presenter is Tripp Hereford, and Tripp Hereford is the principal at Hereford Dooley Architects in Nashville, Tennessee, and they focus on healthcare design for the last 25 years. Tripp started with the firm in 2006 and has over 20 years of architectural design experience. Originally from Pell City, Alabama, Tripp earned his master's in architecture from the Catholic School of America in Washington, D.C., and has been actively involved in many organizations, including the AAH. His healthcare portfolio of work includes acute care facilities, medical office buildings, outpatient facilities with a particular focus on emergency departments over the past decade. So I think we can go on to the next slide. Our course description. The course description will present 4 strategies that we've been looking at that were deployed for COVID-19. Next slide. And our learning objectives include to understand the drivers that create the need for quick solutions to be put into place to handle and treat COVID-19 patients. Learn why some strategies were successful and some were not. Understand how to implement quick interventions in existing healthcare facilities that improve infection control and patient care, and be able to implement sessions learned in future healthcare projects. I'm going to kick off this with a quote from Dwight D. Eisenhower. Our real problem then is not our strength today, it is rather the vital necessity of action today to ensure our strength tomorrow. And with no further ado, here is Tripp Hereford.
And I think we just lost Tripp.
I think we did too. Technical
I'll start. We did this together. I'll start, and as soon as he comes back, I'll hand right back to him.
Okay, sounds good.
So we'll start with how we got here. We all know that back in January, we started hearing about this weird disease coming out of Wuhan, China, and people were getting infected with it. And it quickly spread like wildfire around the world. So looking at the United States, as of the 28th, so 2 days ago, we had over 4 million total cases, 147,672 total deaths just in the United States. And you see the chart at the bottom of the new cases by day, and you see which way it's been trending. Now, there's a little bit of a plateau, which we hope might remain a plateau and not just another stop before we ramp up some more. But needless to say, it's a serious pandemic.
Hey, Mark, thanks. I don't know if y'all can hear me now. I'm sorry I lost the connection.
I'll let you pick right back up, Tripp.
Y'all got me. I apologize. So obviously what we've seen there is, and what we really want to focus on today is, what are we doing to care for the patients and to withstand this surge that's possible in the hospitals. We want to flatten the curve. You've heard that expression over and over again, and it's meaning to reduce the surge of patient flows into hospitals that could possibly overburden them and overrun them and not allow them to complete the care that they need to do. We also want to look a little bit at protecting the HCPs. That's the healthcare providers. That's the doctors, the EMS crews, nurses. Everybody's involved. How does good design affect that? The good news, and you can see it from the report here on the bottom of the screen, is that generally through proper PPE equipment and good healthcare design, the HCP cases themselves are much lower than the general population, even though they're exposed to a greater risk factor with COVID. So next up, Mark. So what's happened? What are we doing to relieve sort of this stress on the hospitals itself? Beginning back in March, CMS suspended hospital visits to allow the facilities to focus really on the pandemic and be prepared for what's coming ahead. On March 13th, there was a federal public health emergency declared, which allowed for less strict compliance with NFPA 99 and the 101 Life Safety Code. That opened up the opportunity to use more, not what we refer to as non-hospital sites. You know, hear us talk about ACSs or alternative care sites. That's how they've been allowed to be utilized. And then CMS really took a stance and focusing in on these equivalency clauses. When you hear that term, that's what we're talking about. We realize that some of these temporary facilities may not have everything that a hospital does, but it may be close enough that you could provide still the care that's needed. And finally, we should point out one of the bigger accomplishments that CMS has brought on from this is their expanded telehealth services. That's going to cause, I think, a lot of improvements over the years on where we see healthcare in the future, and certainly what's going on now with the lack of available beds. Next up, Mark. Yep. So the first topic up we want to take a look at is the alternative care sites. These are really large alternative care sites being utilized. This would include indoor arenas, convention centers, gymnasiums, or other large gathering spaces, throughout the country. The Army Corps of Engineers, they've got exterior tents that they can pop up that they call the federal medical stations, which are equipped with, maybe 250 beds at a spot. But we're not going to focus on those. We're really going to focus on the interior versions where they can be, you don't have to worry about the wind, the weather outside. So we're going to show you how that works. The first one up, Mark. A good example here is the Javits Center in New York City. Y'all probably heard about it, or maybe you attended the AAH convention there a couple of years ago even. But it drew a lot of attention, obviously, for New York when they had their pandemic outbreak. This was one of several sites throughout the city that opened up to initially take on non-COVID patients. It opened up in March, and in a matter of about 4 days, they had over 1,000 beds, and in a few weeks later, they were up to 2,500 beds in this site. Eventually, the building did get as much use as they expected. Nearly 1,100 patients are all that they saw. Part of that is, proper care or proper self distancing and social measures within the city really prevented a lot of the needs for this facility. We'll take a look at a couple of maybe the pros and cons of what's going on here. We'll go to the next slide and just look at really the advantages of a large scale ACS. First off, wide open floor plans. It really leads itself to great flexibility and expansions. You could go from that 250 bed to 1,000 to 2,000 really easily. The center itself is set up for large scale deliveries. They don't have to worry about loading trucks not being able to get to the equipment or storage. Concrete floors, right? Easy to clean, makes it pretty simple. And then the center itself usually has a great infrastructure in place. It runs like a little city already. Ample power. It usually has generator, water supplies, access to a lot of parking, or in this case, most convention centers are centered in metropolis areas, and so they're going to have good public transportation to get you there. Fully enclosed, temperature controlled, all the kind of good stuff, and able to handle a lot of the larger populations. However, some of the disadvantages, next slide, right, might be that there's a bunch of entry points. Here you're seeing McCormick Place in Chicago. There's multiple points of entry that have to be secured. You've got a lot of public facilities that can't meet the cleaning aspects and the social distancing. Just imagine what it was like when you go to a major event in an arena and the backlog of people going to the bathroom. That's not what you want in a situation like this. So you're having to really separate and create your own sanitation infrastructure. Normally you don't have any showers, so you really want that ratio about 1 to 25 or toilets at 1 to 20. And it's also quite difficult to think about this, getting the sprinkler system down. Those sprinklers are up 30 feet in the air. And if you've got a room that's enclosed, how are you providing the sprinkler system? So we really get into those equivalency needs with the local AHJs. Airflow is always a concern. And the fact is, there's just not that many of these sites, 250 throughout the entire country. We got some states that may only have one or two in the entire state. So it can be difficult. The next option we want to take a look at some alternate care sites where you may have heard about dorms and hotels. This was floated, not really used too much, but they really were taking abandoned hotels and dormitories that weren't being utilized and converting them to an ACS structure. Like the convention centers, these sites were obviously they're not hospitals, so you've got to go look into the equivalency clauses and talk with your local AHJ about what they're going to allow. The hotels themselves, they follow some standard design standards from the federal government. Most of them are going to require major renovation. To get it to be brought up to speed, and that's going to take time. It's going to take money, and certainly not as quick as what those large-scale events or centers could bring. Unfortunately, that's the sad side because these spaces are not utilized. These hotels at the time were very underutilized, and dorms were empty. They're great configurations in terms of private bathrooms off of all the rooms. So why don't we look at a couple? Another key aspect is part of the federal requirement is that these have to be within 10 miles of a hospital or 30 minutes of travel. So it's going to be difficult. But a couple of the advantages, and we'll show a couple on the screen right now. One of which is obviously the large availability. There's 54,000 hotels throughout the country. A lot of them are as we mentioned, underutilized, and they have nice private baths. May not all be ADA compliant, but the rooms are made really for if you could think of it, you sort of overlay this plan. It almost looks like a healthcare room. The example here on the screen, this is just showing you one of the rooms that could get converted. The items highlighted in green, like the bed, tables, and dressers, that's all hotel furnished, whereas the red items are things that are brought in, and that includes cubicle curtains and PPE equipment out in the hallway. But difficulty here is you got to rip out all that carpet. You need to put a hard surface down. So you're going to have to renovate this. You're going to remove all the bedding, the nice comfortable bedding that you get at the Hilton Garden Inn. You got to put in some stuff that's easier to clean and washable. Good thing is, hey, you got great Wi-Fi. Sometimes maybe a good TV infrastructure you can watch, and that's about where we end up leaving. Besides HEPA filters, you lack emergency power at typically most of these at these hotels, so you're going to have to get that added in there. Some of the other disadvantages: inconsistent HVAC system. You really have to evaluate from an engineering side. How are you going to properly care for the people down the hall? They really like to see those through wall units. The old school through wall units are actually an advantage here because you're not recirculating the air. Otherwise, you need to deal with your those shortfalls. So obviously, no smoke compartments. This is the whole list there of healthcare items on the right side. That's just issues that we can't really address in this design because it's not a healthcare. The corridors are too small, right? You can't really get gurneys in there. How do you deal with nurse systems? One that always bothers me is the self-preservation. You don't have smoke compartments anymore. So again, it's communications that have to open up with your local AHJ and talk about what equivalencies measures would be acceptable to everyone. This is just an example on the screen of the Army Corps' sort of layout there, and you can see that 40% of the floor plan is taken up by other use, right? Not patient rooms. So it's not all that efficient, but it's certainly a good start. So with that, I turn it over to Mark. Let you run with it.
So I'm going to talk about modifications to existing hospitals. So one of the things that happened immediately is that you had hospitals that had maybe 10% of their beds were intensive care unit beds. In the beginning, nobody really knew whether all the patients needed to be in isolation rooms or you could put them in regular patient rooms. So generally, the COVID patients were going to ICUs, and some of them were that sick that they needed to be in ICUs. So different health systems came up with different strategies for coping with this. Part of it was the influx to the ED. How many patients are we going to have showing up at our emergency department that need care, and can we handle them? So this is actually Vanderbilt University Medical Center. They took part of one of their parking garages and converted it to basically a triage unit. And so, you know, it was an existing structure, relatively easy to deploy and activate, relatively inexpensive. You can see they had to put up some walls, they had to put down some floor finishes. You can see in the picture the transition between the vinyl floor finish and the concrete in the garage. Cons, patient flow is a challenge. It's remote from the emergency department. It's, in Vanderbilt's case, across the street, having to transport patients across the street, limited control for airflow, and because it's a parking garage, it's difficult to heat and cool. So those are some of the issues. Another thing that we saw was kind of a quarantine unit. So basically, for those of you that were in the session 2 weeks ago, Gerald Versalis talked about this same concept and talked about the airflows. So I'm just talking about, you know, temporary walls, sectioning off a portion of a patient wing. The caretaker enters, number one there. Number two is the patient room. And number three is where they remove their PPE, dirty area. You go from 1 clean to 3 dirty, and then exit one-way traffic flow for the caregivers out of the unit. And so the pros, relatively easy to implement. It does embrace the current best practices, which are not isolation rooms for all the patients, but simply that the unit is a negative pressure to the rest of the hospital. And this is scalable. Cons, it requires temporary walls, requires air filtration units, and they're limited door widths if you're putting these new doors in the middle of an existing patient wing. Another one that we saw was the subdivision of an existing ICU. You can see there they used a kind of a modular system with the door. You'll see it's just a plain old doorknob. That didn't look good to me. Lots of germs on that doorknob. You know, hospital latch would be better. If you walked inside, what you would have seen is an air unit and flex duct going everywhere. So pros, it was an existing space, relatively easy to deploy and activate, relatively inexpensive. Again, you've got limited door width into the unit, and all that flex duct with all the little perforations in it and areas, that's hard to clean. And the appearance of it, if I'm a patient and I get wheeled into there, I'm looking at this thing going, what in the world? What are they putting me in? Does it really work? Did somebody just put this together overnight? You know, am I safe? So I think that's an important part of all this. Let's talk about triage tents. So triage tents were deployed by a lot of hospitals. This was pretty widely used. And this is one at a hospital that we actually designed. And so they used it as a patient screening area. So you can see in the little diagram, you have a walk-in patient that's going through the triage tent before they're even allowed inside the building. So they're getting screened, and infectious patients are most likely being taken to the ambulance entrance, so they're not parading through the waiting room inside the ED. And I will just quickly say, ED waiting rooms, for those of you that don't know, are negative pressure spaces. They're 100% outside air. So when you are in an ED waiting room in a modern hospital, you are in an environment where fresh air is being brought in continuously. An essential visitor would bypass the triage tent. They would still be screened but allowed into the building. And the other thing that goes with this, most hospitals shut down their front doors. and were only allowing people in through their ED entrance. So a lot of hospitals banned visitors, and so they were controlling access to the facility, and this does facilitate that. So the pros, Triage Tent, it's easy to deploy and remove. It's a tent. Works well with existing patient flow and entrances. There are usually concrete pads there, there's space there, and it's inexpensive. This is not a real expensive intervention. What are the cons? Well, there's limited control for airflow. Most of them that I have seen, they might have a negative air machine to keep the place at a negative pressure, but they're not conditioning the air in those tents. So it can be hot or it can be cold. If you try to heat or cool it, it's difficult. It's a tent, it's fabric. And surface cleaning is a challenge. You know, if you think about that first slide I showed, you could see dirt on the concrete. It's just, people are tracking in rain, mud, you name it. So surface cleaning is definitely a challenge in those scenarios. So let's talk about the future. So what do we think is happening? So Tripp and I had a few ideas as we were going through, and our overriding concept was flexibility is the key. If you go back to the Eisenhower quote, what we're really doing here, yes, we're dealing with the current needs, we're dealing with the current emergency, but we're also thinking about the future. We're architects. We love to solve problems. We love to creatively solve problems. So we want to think about the future. So some of the concepts that we came up with were bifurcated units. So bifurcated unit basically means we're taking a unit and we're splitting it in half, where we wouldn't have split it in half in the past. So that could be an emergency department, which we actually did a number of years ago. Hospital in Missouri, we split the ED in half, again, thinking about the future, and 2 air handlers, one serving one half, one serving the other half, smoke barrier down the middle. And so one air handler could keep that whole half negative, and you could have infectious patients or contaminated patients in that half. The other half would run normally. So that's one way to bifurcate an ED. On a patient unit, it might be taking a typical racetrack design and splitting that in half. One side of it is a quarantine unit, the other half is not. And under normal circumstances, it's just one unit. The doors are on hold opens and they're held open. Changeable airflows, the ability through the building automation system to change an area very quickly from either a neutral pressure or a positive pressure to a negative pressure. And that there is a definite learning curve there for the AHJs. Typically that's not allowed in most cases, but we think that might happen in the future. Another one, Tripp and I've done a lot of EDs, and we were thinking that we might end up moving the decontamination shower, which is required in every ED. It's normally located, has to be a minimum of 10 feet away from the ambulance entry, but locating it really halfway between the ambulance entry and the walk-in entry so that patients could be funneled through there in this kind of situation. Think about that in combination maybe with the tents. Cross-utilize outpatient prep recovery and the emergency department. So we've done that before as well. We've located in a small hospital at the emergency department and outpatient prep recovery adjacent to each other. And the thinking originally was, well, at night, the outpatient prep recovery area is empty. It's not used. So if you had some kind of mass casualty event at night, then you could overflow patients from the ED into that area. Now, with COVID, we saw elective surgeries being stopped, and you still see that in some of the really, really hot spots. And so again, those beds are empty. That space is empty. If they could be cross-utilized, that immediately builds in more emergency department capacity. But we're interested in your thoughts. So Trip and I wanted to make this participatory and would love to hear thoughts from some of you. What do you think? If flexibility is key, what are some things that you saw today or that you've been thinking about?
So Mark, one thing I'd add to this that's we talked about briefly earlier was just the telehealth improvements and the technology improvements that we could see utilized in the healthcare. You and I spoke about the option of what if you had the remote check-in operations that as you come into the ER, you're in the parking lot before you even get out of your car or on the way to the car, you've already checked in to the facility.
Mm-hmm.
You already know which door to go to, and maybe they want, if you're a high risk, you go to that door that we talked about, the decon shower entry versus, or going through the ambulance entrance versus coming in through the main entry. A great app, to be able to check that in. We see the technology improving on, the next generation of iPhones and whatever might be out there. Is can they start doing more diagnostic work on on the patient themselves remotely? Stay, like we said, stay in the car until you're ready to come in. Don't overcrowd the ER. Seems like it's a fairly low tech option to give you some flexibility in the future and reduce that overcrowding.
Absolutely.
I know we're certainly running out of time. I don't know if there were any questions that came in.
No, there's not been any questions that have come in, but I did want to pose a question just to throw out there for everyone's benefit. Tell me, or tell all of us, about the innovation you've seen and what has been, you would say, maybe the most innovative or the most helpful in designing healthcare environments that you think going forward. We talked a little bit about telehealth, but is there anything else out there, some innovative idea that's come up that you're having an aha moment about?
I mean, to me, it's still that telemedicine aspect of our design is going to change us. I keep thinking of the exam room of the future is not a 10 by 12 room. It's a server somewhere, right? That's giving you the patient data, and you're able to do some analysis. Perhaps they're able to walk into, example, a freestanding emergency room and get simple blood work done. And these remote sites then tie back into the larger healthcare treatment for that patient, and they can determine where to go next. But that seems like it'd be a fairly easy one to sort of handle in the next couple of years.
Have you heard anything about technology in terms of integrating phones or wearable devices to help maybe do a little triage before somebody or as somebody's walking in that door to upload anything? Have you heard anything of that nature?
There was an article in Wall Street Journal about that the other day, but we're not quite there yet. But I think we'll be there really soon.
All right. Anyone out there want to ask any questions? I think Lauren has opened up all the mics. Well, this concludes our presentation for the day. Feel free to reach out to Mark or Trip for any additional questions you might have or thoughts. They'll be happy to take anyone's call. Our next session is scheduled for August 20th, and it is Planning the Unpredictable. Lauren has posted the link in the chat if you'd like to go ahead and get registered right away for that. And thank you so much for attending. And now we've completed part 2 for another half credit. Make sure that Lauren has your information, and you all have a great day. Thanks, everyone.
Thanks, everybody.
Thank you, Jody. All right.